The national demographics for NSTEMIs include the ages between 69 and 84 and female gender. Modifiable and non-modifiable risk factors include currently smoking, a sedentary lifestyle, obesity, cardiovascular disease, diabetes, hypertension, hyperlipidemia, a cardiovascular accident, and a family history of cardiovascular disease. Other comorbidities that put patients at risk include myocardial infarction, coronary artery bypass graft, congestive heart failure, coronary artery disease, and chronic kidney disease. In comparison to national demographics and associated risk factors and comorbidities, my patient was a 79-year-old female with a sedentary lifestyle due to a cardiovascular accident and a history of hypertension, hyperlipidemia, diabetes, congestive heart failure, coronary artery disease, and a family history of cardiovascular disease. For the purpose of this project, I included this slide that compares STEMIs and NSTEMIs. Presentation for both and any other acute coronary syndrome is the same. We rely on diagnostic testing such as EKGs and troponin labs to differentiate the two. There are several risk factors associated with NSTEMIs, which we discussed during the first slide. Along with that information, Avidal noted that by the age of 75, 78% of men and 86% of women have cardiovascular disease, which can lead to acute coronary syndrome and ultimately an NSTEMI. Typical presentation of an NSTEMI is crushing chest pain that occurs at rest or with little activity and lasts for greater than 10 minutes. This pain may radiate to the arm, neck, and/or jaw. Other typical symptoms include dyspnea, nausea, vomiting, syncope, fatigue, and diaphoresis. Atypical symptoms may include a stabbing or pleuritic pain, epigastric or abdominal pain, indigestion, and isolated dyspnea. One nursing intervention is the ABCDE assessment. This assesses airway, breathing, circulation, disability, or their level of consciousness, and exposure, which means abnormal signs. Other nursing interventions include monitoring vital signs for a possible recurrent episode, including pain description and intensity, checking IV patency, and maintaining a position such as semi-Fowler's that can facilitate oxygenation. The first diagnostic test with the onset of pain, chest pain, should be an EKG. This is able to rule out a STEMI as well as the possibility that the chest pain is non-cardiovascular related. ST depression may indicate NSTEMI but cannot be officially diagnosed without a troponin series. Normal values are considered to be between 0 and 0.4. If the troponins come back negative, they should be redrawn in 3 to 6 hours. Pharmacological treatment includes the mnemonic MONA, but not in that order. First, administer aspirin per MD orders, which inhibits platelet aggregation and vasoconstriction. Next, apply oxygen if not already. Then, administer nitroglycerin sublingually up to 3 doses every 5 minutes while chest pain is occurring. This will cause arterial and venous dilation to reduce pre- and afterload and decrease oxygen demand. Last, if chest pain is still occurring, administer morphine per MD orders. This will alleviate chest pain as well as reduce oxygen demand. Just be aware of side effects such as respiratory depression. The first assessment data that was collected from my patient was complaints of chest pain and shortness of breath at rest. I know that there are non-cardiovascular causes of chest pain such as pneumonia, pneumothorax, and GERD, so I asked if she could describe the chest pain and intensity as well as any alleviating factors. The patient had a history of cardiovascular accident which resulted in right-sided weakness and expressive aphasia, so it was hard for her to communicate. I focused on her medical history, which indicated that she had a lot of risk factors associated with an NSTEMI. An EKG was performed and showed ST segment depression, which is indicative of an NSTEMI. Along with the EKG, a troponin series was drawn and resulted at greater than 10. Until she could be transported to the cath lab for stenting, because she was not a candidate for a CABG, my goals were to promote systemic perfusion, oxygenation, and monitor for signs of reoccurrence. Nursing interventions that I implemented to achieve these goals included providing supplemental oxygen, Q2 hour turns, and monitoring vital signs, including her chest pain. The outcome was that we kept her perfused and oxygenated until it was time for her percutaneous coronary intervention or stent placement. Our goal was achieved. This is an algorithm that I've created in order to care for patients who have NSTEMIs. When the patient arrives to the floor, we want to determine whether they are symptomatic or not. If yes, we move to the left, start with our ABCDE assessment, which is airway, breathing, circulation, disability, and exposure. Is their chest pain crushing? Do they have symptoms of syncope, fatigue, diaphoresis? If not, then we move to the right, go over our old carts for their chest pain, check their vital signs, hook them up to telemetry, get an order for an EKG while we call the medical doctor. If they do have crushing chest pain, syncope, fatigue, diaphoresis, we'll go down on the left side to yes, check their vital signs, apply 2 liters of oxygen via nasal cannula, check IV patency, and get an EKG. If the EKG results in ST depression, it means that they are high risk for an NSTEMI. We'll continue down the left side, call the medical doctor for orders on nitroglycerin, morphine, aspirin, and a troponin series. If their EKG does not show ST depression, we'll move back up to the left for no, go over old carts, vitals, get them on tele, call the doctor, and get an EKG. If our troponin series does show elevation, which means that it's above 0.4, we'll prep the patient for the cath lab, gain consent, go over a pre-procedure checklist, and administer ordered medications from the doctor. If there is no elevation in the troponin series, we'll redraw in 3 to 6 hours to make sure that they haven't risen since then. And if not, then we'll go back up to the right with our no, maybe get an order for a stress test, CT, MRI, and possible angiogram depending on what the doctor wants. Ultimately, before discharge, we want to go over their modifiable risk factors. We want to talk about smoking cessation, exercising, and their weight, going over a heart-healthy diet and how they're able to manage diabetes if they have that risk factor. The key points of my presentation include risk factors associated with acute coronary syndrome and ultimately an NSTEMI, the difference between an NSTEMI and STEMI and how they are diagnosed, the importance of determining whether chest pain is cardiovascular or non-cardiovascular related, nursing and pharmacological interventions up to stenting to perfuse the vessels is necessary in order to decrease damage dealt to the heart, and how to care for a patient if they arrive with chest pain.